Welcome to our VETS 2017 Introduction to Field Anesthesia video. This is required viewing for anyone participating in an VETS field clinic. We hope this helps you prepare for your upcoming experience and serves as a useful review for those wanting to brush up on their field anesthesia. Let's start by talking about how to change your needle correctly. I know this may seem unnecessary, but the number of people who contaminate their syringes when changing their needles is disconcertingly high. The world is dirty. Your needle and syringe are not only clean, but are generally sterile prior to opening their original packaging. If you set your clean syringe down, or if the lure of the syringe touches anything, you have contaminated it. The only exception to this involves the use of a sterile field, which we will not have during a routine castration. Do not risk contaminating your syringe and needle. This is not a difficult concept, and we expect you to use this method when changing your needle. Anesthesia is the art of poisoning something just the right amount. Extending surgery or anesthesia unnecessarily is unethical as it causes the patient harm and suffering. Students don't learn anything good from being over their heads or being allowed to muddle or fumble through a procedure, and again, this unquestionably causes harm and suffering to the patient. Worse, many students develop very bad habits when this is allowed to happen. Students do not have a God-given right to practice on a live animal. They do, however, have an obligation to their patient to perform due diligence by practicing adequately to prepare for the procedure beforehand. Wouldn't you expect the same of a doctor working on you? Students working with us are not permitted to cause an animal to suffer in any way due to lack of preparation and adequate practice. Many of our patients are intractable and therefore will not have a traditional physical exam. This does not mean that we are not doing a physical exam of sorts. All of the bolded items on this slide can be evaluated simply by looking at the patient. This information can then be used to make a decision regarding the suitability of a patient for anesthesia. There are many factors that must be considered when making an anesthesia plan. These include availability, benefits of use, patient behavior, potential adverse effect to anesthesia or recovery, negative systemic effects on the patient, as well as the cost of anesthetics. In general, the anesthetic requirements of an equine patient with the same level of training and socialization are the highest for the mule, second highest for the pony, followed by the burro donkey, and finally the horse. Other factors affecting anesthetic requirements include patient temperament and level of training, level of excitement or stimulation prior to sedation, breed, age, health status, and patient position during surgery. As the patient's level of training increases, its anesthetic requirements will generally decrease. A completely untrained animal will often have a higher anesthetic need. By the same token, a very excited horse, even a very well-trained horse, will likely have a corresponding increase in anesthetic requirements, where a calm horse, even with a lower degree of training, will have a lower overall anesthetic need. Age can also affect a patient's anesthetic needs, although this is quite variable and may in fact be due to an individual patient's temperament rather than age. That said, I'm never surprised if an old broodmare requires a higher than average amount of anesthesia, and I hate to go without benzodiazepines in my geriatric patients. Breed also affects a patient's anesthetic requirements, with thoroughbreds having the highest and draft horses having the lowest. Miniature donkeys are reported to be more sensitive to anesthesia, and I respect those who believe this. However, I have not personally experienced this when working with miniature donkeys. I do feel that donkeys are more sensitive to benzodiazepines and generally use a lower dose when working with these patients. You should always keep in mind the patient's health status when considering your anesthetic options. However, some of the horses that seem to fight anesthesia the hardest are also in the poorest health. Dorsal recumbency will always increase the anesthetic needs of the patient and compromises the patient's respiratory and cardiovascular function due to the amount of weight pressing on the lungs and heart from the intestines and other internal organs. This cannot be overstated. This is also true if your patient's head is lower than its hind end. Even small inclines have the potential to increase anesthetic needs. A patient on its side with its head level with or above the level of its gut will always need less anesthetic than it would in dorsal recumbency or on a slope with its head low. All increases in anesthetic administration or length of anesthesia have the potential to decrease recovery quality. That's not to say that you can't have beautiful recoveries even in the face of any of these factors. Just keep in mind when planning that these factors have the potential to cause you grief. Your patient's temperament and level of training, level of excitement prior to receiving its sedation, breed, age, level of pain during and after surgery, intraoperative position, and quality of individual anesthesia will all affect your potential for a less than ideal recovery. There are strategies to mitigate the effect of all these factors that I would urge you to employ or at least to consider. I generally lightly sedate my patients prior to moving them, and I don't separate friends. If a horse is waiting to go to surgery and has a buddy with it, I sedate the surgical patient with the companion present. I would go so far as to administer my induction and then walk the other horse away. If both horses are having surgery, I would first sedate the less nervous patient, as this horse may not be less nervous after his pal leaves. Then sedate the more nervous horse prior to walking it to the surgical area for induction. This method will require that you resedate the second patient having surgery, but anesthesia will not be compromised by the horse fretting while he waits his turn. Take care not to fight with an untrained or poorly trained horse prior to sedation and anesthesia. If a physical exam is going to compromise the patient's anesthesia and recovery, I would rather skip it. If we find that the patient is febrile after induction, we can always cancel the surgery and recover the patient. Everything possible should be done to keep the patient from becoming excited before surgery. You can generally reduce the amount of sedation given to draft horses and still obtain adequate sedation for quality anesthesia. However, if the animal is completely unsocialized or is feral, this will generally not be the case. Pain during and after surgery can be addressed to prevent wind-up and thus decrease overall discomfort. To address this, use a local block and administer anti-inflammatory drugs when possible and appropriate, and consider using an analgesic epidural. Patient positioning should be performed in a way that decreases overall anesthetic needs. Avoid dorsal positioning when not absolutely necessary for the procedure. Some procedures will require that the patient be in dorsal for the entire surgery. For other procedures where dorsal positioning is necessary, roll the patient into a lateral position as soon as you can. The surgery staff should never lean, lie, or sit on the patient's abdomen or chest. This compromises the cardiovascular system and potentially recovery. Using your patient for your own comfort is unacceptable. If your anesthesia was not as smooth as you would have liked, there are some strategies you can use to help ensure that your patient experiences the best possible recovery. Leave the eye covered until you're certain the patient is ready to get up. Give post-op xylazine to help reduce stimulation. Maintain silence and stop all activity around the patient. Apply fly spray if insects will be an issue, and allow the patient to sleep it off. Geriatric patients will often suffer from arthritis of the hocks and won't be as strong as other patients after surgery. Gaited horses may be weaker in the hind end, and any injured horse may have more difficulty rising after surgery. In all of these cases, a tail-assisted recovery may be necessary. Availability issues can affect the anesthetic protocol that you use. Depending on where you're working, any of these common anesthetics may be unavailable, making it necessary to adjust your anesthetic plan. Xylazine is an alpha-2 adrenergic agonist. More simply stated, it stimulates or potentiates the alpha-2 receptors found in the animal's cells. These receptors are found in the nervous system as well as other organs. Alpha-2 adrenergic agonists stimulate receptors in the same system as does adrenaline, also called epinephrine. On the other hand, an antagonist would block stimulation of the receptor. Xylazine provides sedation as well as some analgesia. It's short-acting, which is desirable in field anesthesia, and its sedative effects are essential for smooth anesthesia with dissociative agents such as ketamine, which we'll discuss in just a moment. While xylazine does slow intestinal motility in a laboratory setting, there's little evidence that this is a clinical problem. As one would expect from an alpha-2 adrenergic agonist, there will be some blood pressure changes, but again, this has not been identified as something that would put a patient at risk. Because repeated doses of xylazine can prolong the sedative effects, it can negatively affect recovery by promoting stumbling. On the other hand, very small doses given post-op can decrease anxiety in a recumbent horse and actually ease their efforts to stand. Balancing these effects requires individual patient monitoring and experience on the part of the anesthetist. Butorphanol is a synthetic opioid partial agonist and a Class 4 controlled substance. It's used in a variety of species as an analgesic, though very short-acting, a mild sedative, an antitussive, and an antiemetic. Our interest in butorphanol is in its ability to potentiate alpha-2 sedatives like xylazine, which decreases the volume of sedation needed. It provides very short-acting pain control, possibly for 45 minutes. Experience suggests that it decreases the tendency for horses with alpha-2 agonist sedation to startle and kick. Some practitioners call this planting the hind end. As is the case with xylazine, butorphanol has mild intestinal effects, which do not seem to be clinically significant. Head twitching or bobbing, known as torb twitches, can occur in some individuals. While they can be annoying, especially in dentistry, they do not seem to affect later anesthesia. More significantly, when doing some standing procedures or when inducing for anesthesia, some horses will want to walk forward when butorphanol is used. This is especially true as the dose increases. In these instances, you can simply head the horse into a corner or elect to induce anesthesia while they're walking. These benzodiazepines are Class 4 controlled substances. They provide excellent muscle relaxation and can really smooth out your anesthesia, though it's certainly possible to run high-quality anesthesia without them. That said, I use either diazepam or midazolam with every patient when possible. At volumes half that of your induction ketamine, for instance 5 mL of Valium or midazolam with 10 mL of ketamine, your anesthesia time is increased by about 5 minutes. Using a benzodiazepine in donkeys and mules immediately after administration of a sedative prevents the very occasional but dramatic excitation that can occur in these animals. This method also helps prevent donkeys and mules from being startled out of their sedation and allows for a quiet, early induction. At times and in some places, benzodiazepines are prohibitively expensive or unavailable. If I have a limited supply, I save these agents for geriatrics, donkeys, and mules, and for procedures that require a patient be in dorsal recumbency. Ketamine is a Class 3 controlled substance that provides dissociative anesthesia and may provide some analgesia. Adverse effects associated with ketamine include cumulative effects on recovery time and quality. Anesthesia with ketamine coupled with xylazine sedation has been a major improvement over previous protocols using barbiturates and other drugs. GG has been used for a long time in equine anesthesia and has significant benefits as a muscle relaxant. On the other hand, a much larger volume is required than in a standard ketamine benzodiazepine protocol, and recently there have been problems with availability. Some anesthetists feel that the advantages of GG can be achieved with benzodiazepines and that these alternatives are much more convenient. Guaifenesin or GG provides good muscle relaxation during anesthesia. However, it's highly irritating and a catheter must be used when using GG. The volume required also dictates that an intravenous drip system be used. Patients may experience weakness during recovery. Further, red blood cells may rupture if used at too high a concentration. Always keep in mind that donkeys and mules are very sensitive to respiratory depression when receiving GG. Lidocaine is very inexpensive and available almost everywhere. It reduces the amount of anesthesia required to maintain a patient and is therefore a part of a balanced anesthesia plan. This in turn improves recovery quality and helps prevent postoperative pain. This may also be beneficial in preventing pain windup, which could provide sustained analgesia in castrations. If you've ever tried to pull a hemorrhaging stump out of the inguinal canal for postoperative ligation, you can appreciate the value of a little local anesthesia. The average cost for anesthesia in a 1,000-pound horse in our practice in the United States is under $15. This cost goes up in Latin America where just about everything is more expensive. In some countries, this is even true of lidocaine. These costs will vary depending on where you are, as well as things like what brands you choose to purchase. All anesthetic protocols are simply a place to start. No one protocol or rate of administration will fit all patients. The protocol will not evaluate your patient's behavior, level of training, or health status for you. It can't adjust itself based on the patient's reactions. It's your responsibility when administering anesthesia to evaluate, plan ahead, and monitor. Your protocol will always need to be adjusted based on patient response. The most basic anesthetic protocol is the xylazine ketamine protocol. Perfectly good anesthesia can be performed using this approach. However, I always prefer to add a benzodiazepine when possible, and butorphanol is really handy, particularly in difficult patients. This chart simply shows where our basic protocol falls in the range of use for each of the components that we utilize when running field anesthesia. From the basic anesthesia protocol, we can create a chart as a handy reference, but it really doesn't reflect the complex factors you should be thinking about when preparing to anesthetize a patient. If we expand the previous chart, we can arrive at a better starting point for an assortment of patient species, breeds, and behavior types. However, this is still just a bunch of numbers and only a place to start. Do not use charts as a set of hard, fast rules that will always be perfect. Charts are not a substitute for experience, training, or judgment. In general, it's pretty safe to take the numbers from your initial ketamine dosing calculation and increase them by 2 mL for your average adult horse having a procedure in lateral, and by 3 or 4 mL for that same patient if they're going into dorsal. For a 400-pound horse, I would increase by 1 ml of ketamine for lateral and 1.5 to 2 mL for dorsal. I would much rather start with a higher dose and have a patient sleep a little longer than risk chasing them with anesthesia, thus compromising both anesthesia and recovery. Wild horses that must be handled in a chute lack training and socialization. This increases the patient's anesthetic needs. Lloyd's xylazine package insert states, xylazine has been tested in horses at 5 times the recommended dose. However, doses of this magnitude may produce convulsions and periods of prolonged sedation in horses. That said, we routinely use twice the normal dose of xylazine, or 2.2 mg per kg, to sedate really amped up feral horses in order to achieve sedation and quality induction. There are others who would start the same patients at 4 times the normal dose, or at 2 grams of xylazine in a 450 kilogram horse. The biggest problem that people have with donkeys, or rather that donkeys have with people, is a lack of understanding of donkey behavior. Donkeys are adapted to living in areas with little food and water. In this environment, it's necessary for them to live a solitary life. They will live in herds when resources are plentiful, but they're behaviorally adapted to living alone. When at risk, a herd of horses runs together at the same pace, making it harder for a predator to pick out a single victim. The donkey, on the other hand, when living alone and therefore being the only one faced with the threat, tends to freeze and think. What we humans may see as stubbornness is really just a donkey trying to sort out a problem. Further, they're generally much more worried than the inexperienced onlooker would realize. A head held high, ears at attention, the slightest swish of the tail or flick of an ear should clue you in that a donkey is quite frightened and is probably hoping that if they just stand still enough, you'll leave them alone. Try working on donkey time and allow them their donkey moment. Things will usually go much faster. Another difference, again due to the solitary lifestyle, the donkey is more prone to fight than flight. Where a horse's first instinct is usually to get away, the donkey will more often simply stand its ground. Failure to recognize the degree of stress a donkey is feeling leads to a failure to increase the anesthetic dosing appropriately, causing an inadequately anesthetized patient, giving rise to chasing the patient with anesthetics, which may lead to a poor recovery. With donkeys, I generally start with sedation by weight at 1.1 mg per kg of xylazine, followed by immediate administration of a small dose of benzodiazepine. They may very rarely lie down after the benzodiazepine, but I want them on the ground for surgery anyway, and I don't worry if I have to induce anesthesia while they're lying down. If they're at home, in a quiet situation, I would then induce with a thoroughbred dose of ketamine, that is 2.75 mg per kg. If they're not at home or the owner has already upset them by moving them away from their friends or some other nonsense like that, I increase the ketamine dose to about 3.6 mg per kg. I usually use 5 mL of ketamine for a 300-pound donkey in a busy clinic. If they have not sedated well, after their initial dose of xylazine, I give another half ml of xylazine and then induce. Keep in mind that a group of strangers standing around staring at you might feel an awful lot like a pack of predators ready for a kill. Additionally, if you were a smart donkey, and I don't know any dumb ones, and you'd been standing around watching animals fall to the ground, you might very well believe that all of your friends were dying. It's not hard then to picture why a donkey might not want to cooperate. Mules are a whole nother category. They're way smarter, way faster, and way stronger than any biped. Don't short your mule on sedation or anesthesia. For starters, increase your xylazine by 50%. I also like to get some benzodiazepine on board immediately after my sedation to prevent the occasional excitation that you sometimes see in a mule after alpha-2 sedation. Remember, just like with donkeys, they may very rarely lie down after the benzodiazepine, but I want them on the ground for surgery anyway. Then increase your ketamine by 50% and prepare to top off frequently. In fact, 30 to 50% more frequently depending on the mule. And remember, just like donkeys, mules are very sensitive to guaifenesin and prone to respiratory arrest if you're not careful. If you plan to use triple drip, use the donkey mule protocol, not the horse protocol. I know this is the second time you've seen this slide, but it is truly important. Your protocol cannot run anesthesia for you. It can't evaluate your patient or your patient's response to the anesthetics you've administered. There's no one-size-fits-all. You must monitor your patient and administer anesthesia to effect. Maintaining field anesthesia after induction can be done in several ways. My favorite is through intermittent boluses of 1/4 to 1/3 the initial dose of ketamine mixed with half that volume of xylazine. Depending on the patient, you might be topping off with half a ml of xylazine with 1 ml of ketamine, or 1 of xylazine with 2 of ketamine. Topping with just xylazine or just ketamine will not provide adequate anesthesia and will compromise your patient's recovery. Have boluses drawn up and ready to use ahead of time. Another method for maintenance of anesthesia is triple drip. Triple drip is mixed in a bag or bottle of 5% guaifenesin. Xylazine and ketamine are added in ratios that are different for the horse than they are for the donkey or mule. Not only is the ratio different, but the rate of administration is different as well. Remember, donkeys and mules are more sensitive to guaifenesin and are more prone to respiratory depression and arrest. Your protocol can't monitor your patient, only you can. Again, this chart is only meant to give you an idea of where to start your maintenance drip rate. In general, an average patient of a given size will require the number of mils listed in the maintenance mils per hour column. Of course, we all know there is no such thing as average or normal, right? The chart can't run anesthesia, and you have to monitor your patient and administer to effect. The same applies to donkeys and mules, just a different recipe and a different starting rate. The ratio of xylazine to ketamine is changed, so the patient gets less guaifenesin, reducing the risk of respiratory depression and arrest in the more sensitive burro and mule. Personally, I still prefer to use the intermittent bolus of individual top-offs. Another continuous rate administration anesthesia protocol is double drip. Like triple drip, the ketamine and xylazine are mixed in a volume of sterile fluid and administered at a predetermined rate through an intravenous catheter and fluid admin set. Of course, administration rate will need adjustment based on the individual patient response, and the 1 drop per second is therefore just a starting point. This is a dosing chart for mixing double drip anesthesia. Remember, with this protocol, a bag is mixed for a patient of specific weight and administered at an approximate rate of 1 drop per second through a 15 drop per ml admin set. As always, monitor your patient and adjust the rate as needed for each individual. There are several methods used to induce equine patients. 2 of these are hand induction and loose induction. A hand induction might be done by a tall or short person, with or without tail assistance, or with a swing gait. Other methods include the chute induction and the remote delivery or darted induction. This presentation will only cover 3 types of induction. I will make one comment on tail-assisted inductions, though. Attempting a tail assist on a horse who is not well trained can result in startling the patient, which can compromise your induction. Before any further discussion of induction, a little note on safety. If you don't stay safe, you put everyone around you at risk, and you do not have the right to do that. Stay safe by staying on your toes, both figuratively and literally. Don't kneel. Keep the ball of your foot on the ground so that you can move away from a patient if you need to, and stay out of the danger zones. Never stand with your back to a patient, anesthetized or not. Don't stand in front of the patient or within 6 feet of the legs of the patient. This rule could not be simpler. Also, don't stand between the front and hind legs, and don't stand between the head and the forelegs. While good anesthesia should prevent patient motion and potential human injury, you do not need to be in any of these places, so why risk an unforeseen complication? Safety is the avoidance of the very unlikely but very high impact event. There are a few safety points to keep in mind during induction as well. Don't get your fingers caught in the halter, and stay clear of the front feet as the patient becomes recumbent. During induction, hold the rope carefully to avoid getting a rope burn, and don't fight the process. The patient is ready when the patient is ready. Attempting to topple the horse before it is ready can result in a compromised induction in anesthesia. Begin by administering sedation to the patient, then wait. Waiting an adequate period of time improves induction quality. Early inductions or induction agents injected too quickly generally result in the horse paddling or running in place on the ground after they become recumbent. Do not be careless or complacent around a horse that appears to be sedate. Some of these horses are quite easy to startle, which can compromise your induction. Particularly if the patient was reactive or difficult to sedate, stay quiet and minimize all movement around the patient to help ensure that induction will go well. A short person may not be able to hold a horse's head as high as is shown in the following induction. As you can see, the horse's head is supported or held up until the horse starts to sit back. It's important not to begin this process if the horse is pushing against you because it may tend to fall forward. Wait until the patient starts to crumple, then lift the head and try to get him to dog sit. Then quietly take the head to the side and allow the patient to lie down. As this process occurs, continue to walk to the dorsal side of the horse's neck. A better place for our anesthetist to stand would have been about where the owner ended up. Being a short person, it would be quite difficult to hold a horse's head above its withers. It's much easier to hold the horse's head in line with its body, slightly below its withers, and wait for the horse to begin to buckle and lean back. When this happens, simply pull gently forward to support and guide the horse into lateral recumbence, moving out of the way of the front legs. The most common mistakes made when learning to drop a horse are holding the head too low during induction, causing the horse to flop to the ground like a fish, and staying in the danger zone in front of the horse as it falls. Try to avoid these. Next, we'll cover the chute induction, but first, never turn your back on the chute and always stay clear of it. Why? Got it? This horse was successfully anesthetized, gelded, and had a good recovery. However, had our handler not been experienced with the neck rope, this bronc could easily have come out over the top of the chute. An inattentive bystander with their back turned would then have 1,000 pounds of unhappy horse on top of them. Not a good place to be. Chute gates have also been known to fly open and horses bite or strike right over the top of the fence. If you don't need to be next to the chute, for everyone's safety, stay away. This horse is restrained in a bucking chute with a neck rope in place for safety. Note that the rope will keep him from rearing but does not compress his neck or choke him in any way. Non-essential personnel are back away from the chute to avoid unwanted stimulation. A skilled anesthetist is quietly approaching the jugular vein where she will accurately place a needle with minimal trauma. This requires practice and should not be attempted by individuals who cannot achieve quiet venipuncture on trained horses. Another person is attracting the horse's attention by wiggling his fingers next to the horse's right eye. This must be done quietly and at just the right distance so that the horse does not become startled. As you can see, the horse is watching both the anesthetist and the distractor with his ears. This gives you a few seconds to get the needle placed in complete sedation. Other techniques might include a blindfold placed over the horse's eyes from the catwalk, stroking the hair on the side of the neck, or gently holding some of the mane hairs. It's not possible to predict which of these will work best on a given horse, and chute help should be familiar and willing to use all approaches. While you should limit the amount of time that your hands and arms are inside the chute or between the rails, having one's hands or arms in this position is unavoidable. Don't forget that some horses can and will bite. If an individual makes any effort to turn its head, show teeth, and pin its ears, a blindfold or second neck rope should be applied to protect the anesthetist. Notice here that we are staying back at the point of the shoulder and reaching forward, and not coming in next to the horse's face and mouth. This horse has been induced. Notice his friends watching from the next chutes when the gate is opened. His head is low, the neck rope will be removed, and we're waiting just a second before opening the gate. The exact time interval will depend on how far we want the horse to go before it drops. With really difficult animals, it may be better just to wait and let the horse go down in the chute. The gate is then opened and the horse can be pulled out into the arena for surgery. This does require a fair amount of manpower on an adult horse, particularly if the footing is deep. We're going to let this guy come out on his own. Typically, a patient induced in the chute will just stagger into the open area and crumple quietly to the ground if the sedation and induction process has gone well, onlookers remain out of the way and quiet, and proper sedation has been achieved before induction. This horse is not ready for immediate approach, as he has remained in sternal recumbence. If you or a pack of you rush at a patient who is not yet anesthetized, you may cause the patient to leap up and jog off. Wait. Here, a skilled handler is approaching slowly and quietly to position himself for when the horse is ready to be touched. Once the patient drops into lateral, the crew moves in. Remember, prolonged anesthesia can negatively affect recovery. Don't extend surgery time by being unprepared. And don't rush a patient who is not ready, but move forward as soon as the patient is asleep. After the patient has become lateral, cover the patient's eye to reduce stimulation. Place a pillow below the patient's head to prevent facial nerve damage, a condition that can be transient or permanent and can take as long as a year to heal. For most surgical patients, we'll use direct venipuncture to maintain venous access. The anesthetist's first priority is to gain venous access. This will be accomplished using an 18-gauge 1.5-inch needle through which a dose of flunixin will be administered. After the flunixin has been given, pause for a few moments and then flush your needle and syringe by aspirating about 2 mL of blood into the syringe and returning it to the patient. This is necessary to clear all remnants of flunixin from the syringe and needle. Flunixin precipitates when it comes into contact with any other medication. Don't worry, we're going to help you learn venipuncture in the recumbent patient. This is my favorite way to teach IV injections. The patient won't move, and if your technique is poor, the patient doesn't feel it. This will help you refine your technique before moving on to a standing patient. Venipuncture in the recumbent horse is a really important technique to master. At some point in your career, you may be faced with dealing with this in an emergency. Having mastered this skill before that happens will make a difficult situation a little bit easier to handle. Remember, when maintaining anesthesia through direct venipuncture, you'll need to periodically flush your needle by aspirating blood into the syringe and then returning it to the patient. After induction, the anesthetist should check for depth of anesthesia. A well-anesthetized horse will have no nystagmus. The eye will be central and moist, but not welling up a tear. The palpebral reflex will be slower than normal. The patient will be relaxed with all 4 feet touching the ground and should have a smooth, even respiratory pattern. If a routine castration has a little nystagmus just after induction with a central eye and no tearing, administer your flunixin and wait a few moments to see if the patient gets a little deeper in that time. If not, go ahead and administer a topper. The toppers will be 1 part xylazine to 2 parts ketamine. On an RVETS trip, your toppers will be mixed for you, so don't worry about that. Just make sure that you always have 2 toppers available in your caddy. You did remember to flush your flunixin syringe to clear out any remnants in the needle, right? Perfect. And don't worry about doing anesthesia. You won't be alone. We'll always be there to help you. All you need to do is ask. For crypts, hernias, and patients who are going to be more difficult, the staff anesthetist will do the anesthesia and you will act as an assistant. For a crypt, hernia, or any patient who will be in dorsal recumbency, we need the patient to be more deeply anesthetized prior to putting them on their backs. In these cases, we may top the patient off with a larger dose and we may administer more benzodiazepines. Many of our patients are intractable, so we don't always know if they have a cryptorchid testis. That's why we're always ready. As you move forward in your professional careers, being ready to deal with whatever happens will serve you well in your daily practice. Many students aren't sure they will recognize nystagmus when they see it. Just in case you were wondering what it might look like, here's a short example. We know we increase the anesthetic needs of the patient as soon as they are placed in dorsal. We know we increase the anesthetic needs of the patient as soon as they are placed in a dorsal position, so before we roll a patient onto its back, we must have everything ready, and the patient must be adequately anesthetized. Again, we must always be ready for a surgical emergency or a cryptorchid. This means that once we finish a surgery, the surgery toolbox must be immediately restocked with a surgery pack, sterile gauze, or anything else that was used in the procedure. No 2 patients will respond to anesthesia in exactly the same manner, but there are some signs that are more reliable than others. A tear welling up in the eye is a very reliable sign that the patient is getting lighter, as is an increase in the rate and depth of respiration. Overusing the palpebral reflex will fatigue the lid muscles and render this parameter useless. If this happens, you may think your patient is more deeply anesthetized than he actually is. Remember, you have to read the whole patient, not just one indicator. A good recovery is not difficult to achieve, but you can certainly ruin one by ignoring certain critical factors. In general, if induction and anesthesia were smooth, you can expect a smooth recovery. However, there are a lot of ways you can ruin what could have been a perfectly good recovery. Far too many people rush a recovery only to have to deal with a really ataxic horse. Sudden noises can startle a patient and cause them to rise too soon. Sitting on the neck and talking can be overstimulating, as can constantly lifting the towel to check the palpebral. Waiting too long and then whipping the towel off the eye suddenly or lunging at the patient as it stands may also startle it. Using the patient's head to steady him as he stands prevents him from finding his balance and far too often causes the patient to fall. If a patient needs to be steadied, please use the tail. So what are our first 3 rules of recovery? Well, let them sleep it off. The longer the anesthesia was, the more important it is to allow the patient to sleep it off. And if your anesthesia was not as smooth as you wanted, it's even more important. Most of the time, before the patient stands, there will be signs they are getting ready. If the patient's moving his ears in response to sound, swishing his tail, or twitching his skin at flies, walk to him and check his eye by gently lifting the towel. I usually speak softly to let them know I'm approaching. The last thing you want to do during recovery is startle a patient. If they have no nystagmus and they appear to recognize that I'm there, I remove the towel and wait for them to sit up. If the horse goes sternal and doesn't rise, great. The longer they lie sternal, the more likely they are to stand up beautifully. If when you check the eye, the patient is not ready to rise, that is, there is rapid nystagmus, but they seem to want to make an attempt, there are a couple of ways you can keep them down. Basically, the horse must get its head into a normal, upright orientation before it can stand. The neck and head are critical in allowing normal balance and providing the force necessary to go from a sitting to a standing position. Here, using the nose and ear as levers, the nose is pointed to the sky. The operator's knee is positioned on the neck dorsal to the cervical vertebra to keep the neck down and lateral. Note that the anesthetist's left foot is on the ground and she is not on both knees. While with some strength and determination you can hold a large struggling horse down in this way, the operator needs to be ready to protect themselves by jumping back away from the horse's front legs should they start to lose it. To achieve a safe escape, it's essential to be able to go quickly to a standing position. While Method 1 gives you more leverage, it's also more stimulating to the horse. For that reason, we more often use Method 2. You can't hold a really awake, struggling horse in this way, but you can gently tilt the horse's head when it's just starting to make its earliest attempts at standing. By rotating the head using the mandible and ear and keeping the eye covered, you can often lull the patient back to sleep until nystagmus stops and he's more ready to stand. Note the position of the right knee and left foot are the same as in Method 1. When the horse relaxes, you should release any force to avoid stimulation. When the patient tries again, make an assessment of his readiness and decide to let him up or reapply leverage to give him more time. This does require some experience. Now we'll take a look at a few recoveries. The first is an older Tennessee Walker. He was over 20 years old. Both his age and his breed indicate that a tail recovery is necessary. Note the tail being used to keep him from falling forward and to keep his hind legs from staggering side to side. The person on the head just keeps the rope out of the way and turns his head gently to make him go in a circle. There is no force applied to the head. This is important. Bucky was halter broke, but had absolutely no ground manners. He was quite angry that we wanted to touch him, and of course, he was a crypt orchid. Because higher anesthetic dosing was necessary due to temperament, increase in the length of procedure, and positioning required, this was another instance where tail assistance was a good idea. However, because of his attitude, it's important to be ready to let go of the tail at the first sign that the patient is unhappy and preparing to bolt. Notice the amount of scrambling before he was able to get to his feet. Also, the tail is not used to lift the horse, just to give him something to lean against while he figures out where to put his feet. The tail was released immediately after this picture was taken. Almost all patients will be able to rise on their own from a smooth anesthesia. Over 95% of our patients stand unassisted on the first attempt. Now that's what we want to see. We hope this presentation was helpful and informative. Our training materials can be found at www.r-vets.org.